And that gets harder. All right, so let's talk about another one. Someone bring it up. So how are we going to treat life-threatening? Come on, give me another one. Shortness of breath. Well, let's do a primary assessment on shortness of breath. You come in, someone looks and appears shortness of breath. What is your field impression? Sick. And how do we formulate that? Because you know it's going to be on your test, the history and chief complaint. She says to you, I'm short of breath. Okay? Short of breath. What are you going to do? So the first thing you do is you see she's short of breath.
What's her quality and depth?
Shallow, rapid, shallow, tripod.
Rate?
I'd say rate is probably 36. You can actually hear the fluid. It's audible. Okay, so you've done your ABCs, but even before you listened, what did you see? So what are you going for? Oxygen right away. And what are you putting her on? How much oxygen? Yeah, so you have to start treating life-threatening emergencies if she's got positive. But what do you see here on a CHF? What do I see from here up when I just look at her? Jugular venous distension, JVD, and work of breathing, right? You can actually see the sensory muscle breathing. Okay, good. So you give them oxygen and treat them. It's life-threatening. So what have we gotten through so far? I gave them oxygen just by what? Looking. See how that works? Just by looking. Okay? So the hardest thing is going to be for you guys when you test is looking, doing, and following a sequential thing in order. Isn't that crazy? See what we've got to master now? And I hate to say it to get through testing, but when you get in the field, it will help you, and then you modify. So, oxygen by looking. Then what do I go in and do? A, B, C. What am I doing? I'm A, listening and find out there's rails. Because why do I want to find out about fluid? What do I have to look at with fluid? I want to know how high it is. I want to know how much he's floating. Right? If it's here, here, or here. So we listen, and it's full. Okay, there's full breath. And then what do we always have to check?
Pulse.
Okay, and the pulse. Let's say it's like 60.
When we got the full rails,
We got a full.
do we deem that a life threat again and go back to CPAP maybe before we go into
Thank you. Yes, absolutely. You hear that? You see what he decided to do? And why'd you do that? Because what's going to happen to our patient if we don't react quickly?
we might go unconscious and
Then they go unconscious and die, yeah. So we go to CPAP. So here we are. He's already thinking, I went to the pulse. Well, you get a pulse really quick, and he's thinking, if I don't move quickly and I don't go to CPAP, what happens to my patient? They die, right? Or, you know, what we used to do is to intubate them. So you go to CPAP. That's considered life-threatening. And then what do you do after you CPAP?
go back to our systematic approach.
Reassess, listen, right? And then you have to go back and start where you left off. Where did you leave off? At C. So what's next? Well, next, you have to go into the talking. You can't talk to this patient. What the hell are we going to do? It's the OPQRS sample stuff, right? And then secondary assessment with vitals. Yeah, and you have to modify. Why is the heart rate 60 now? Remember, you have to think critically. So why is my heart rate 60? Patient's in distress. All right, I got him on CPAP. My heart rate is 60. And I need a history, because what can CPAP do to my patient if they have a problem with their heart? It does. It increases thus increasing intrathoracic pressure. Thus, if they are having a heart attack, increases the stemming, or can cause cardiac tamponade. So in the back of your head as a paramedic, I'm getting what on after that CPAP? Or even before I put it, what am I putting on? If they're really critical, I do put the CPAP on. There's no choice. But you want to get out, because what am I looking for in the EKG? You are looking for signs. You're going to see some hypoxia, but you want to see if they're actually having an MI. And if they are, a tamponade is hard to figure out. The EKG plays really bad. But yes, you see how this works? Good.
Okay, I thought most tamponades they can pinpoint chest pain.
They can pinpoint chest pain.
Like generalized or localized.
They can, but don't do it in exact until you're skilled in the field to figure that out. I mean, you know what I mean? Like anybody can say, but you want to look at the EKG, you also want to look at the blood pressure. I always look at the blood pressure with tamponades.
See if it's narrowing.
Yeah, it's a big one. And the muffled heart sounds, you want to listen to heart sounds? Mm-hmm. It's up to you. I was listening to bowel sounds today. That was a wonderful thing when a hernia and a woman had her ass sticking out. Beautiful. But I tell you about belly, right? I always listen to bowel sounds. Whatever. All right, so we went CPAP, but then we're thinking, because what do we think critical, we go to the EKG. So see what's going to happen Saturday? So Saturday, when you're sitting there and you do this assessment now, what do you have to do? You have to apply. What are you applying? What are we using? Toys? Treatment modalities. And we're using our equipment now. So think that way. See how that works? Think that way. So what else do you have to do now? So now we've A, B, C, and I got scared, so I put them on a monitor, right, real quick, and I got my EKG, And then where do you go from there? Where do you go back to? You can go back and reassess if you want. Yes, you should always reassess, but then you still have to go into the OPQRS sample, secondary assessment, focus. You know what I mean? Vitals. Okay, you have to get them. But you could be getting vitals with what? A blood pressure cuff at the same time you're CPAPing. All right? So that's understood how you do that? So that's life-threatening. All right. Let's do another one. Pick another one for treatment. Come on, someone pick it. I don't have to always pick it. Seizure. I love seizures. Love seizures. So you get on a seizure. There's two ways you can find a seizure. There could be multiple ways, but my two are what? How do you find your seizures usually? Actively or? Post-ictal, right. Do you know when I was an EMT, now I spelled, you know how I spell post-ictal? Post-ictal. With a D. Ictal. And when somebody had a cabbage, you know how I spelled cabbage back in the day when I was young? C-A-B-B-A-G-E. Yeah, absolutely. Okay. Or they're post-ictal. Okay, so.
They had cabbage back then?
Yeah, they had cabbage. Yeah, they did have cabbage back then. Oh, yours. Yes, they had. Right? Matter of fact, they started open heart massage in 1965 when I was born at Johns Hopkins, all right? So we had some CPR when I was born. All right. Anyway, so I lost my train of thought. Seizures. Post-ictal. So you arrive on scene. Patients post-ictal. You see a lot. Sick or not sick? Okay. What is your field impression when I walk up? Let's do an adult. Kids are easy. I think kids, viruses are easy. I don't know. So let's do an adult. Okay, so you're looking for a history. So, but the first thing you're doing is when you're looking, you're going, okay, post-ictal. What?
Airway.
Right, so we're looking at breathing. That's good, because that's what you are including. So now he's breathing agonal respirations. All right, agonal. So what? What do you have to do? Yeah, you may want to assist if he's, yeah, absolutely. So what do you, how are you going to do it?
Either OPA or OPA and BBVM.
And he takes an OPA, so that's good, right? And you use it as BVM. And how are you ventilating this patient? This is just as important as what you're doing.
One breath every 5 seconds.
One breath every 5 seconds. Okay, good. So we're ventilating. And how much air are we pushing in? They ask you that question. How many cc's is going in?
Until you see the chest.
Till you see the chest is about 500. Till you see the chest rise. Absolutely, you do want chest rise. Okay, so you ventilate. But now you're thinking, okay, we're ventilating, we got the airway, but there's more to it. We got A down, A airway. Airway is not patent, airway is now patent, airway is established, ventilation is done. What's next? If you can listen to lungs, we're looking at breathing, yes, because you want to make sure it's going where? In and down, because if we don't have adequate tidal volume, we don't have adequate perfusion. Yeah, absolutely. Okay, B, C. Pulse. And the pulse is 130, let's say. You can do an adult. You can. Not always accurate, but you can. Absolutely. Okay. It's actually good. So you got 120. So what are you doing now?
EKG.
Okay, we could throw them on EKG and get a line. We do a lot, right? Multitask. So you want to put them on the monitor. Why do you want to put them on the monitor? Why are you putting this guy on the monitor to see? There could be some determination in seizure. What else?
You said it's very uncertain?
Yeah, he is. Right. What else could you look for in EKG? What could cause a seizure?
Electrolyte imbalance?
Could be. Maybe when it detect. Doesn't it look like a seizure to people? You had it in mind. Who knows? But it also shows hypoxia when you learn about EKGs, right? You can see how, was he really short of breath? Or did he not have enough oxygen? Okay, EKG's on. What's next? You got C, EKG. Line's good. Why are we getting a line? If he has another seizure, yes, or if I need to give any other meds, yeah. Absolutely. And what's going on the whole time with this assessment again? We have to keep moving forward. What's next again? The LBQRST sample, secondary, yes, and vital signs. And that's how it moves. See how this is working now? You have to do this Saturday. You have to incorporate all this stuff. It's pretty cool. Thank you. Who said that? Amanda, you're absolutely right. I would check the glucose on him. Because what happens in seizures? We use up a lot of energy, and we burn off our glucose stores. Yep. And it could be low. And could he have a seizure from being low? Yeah, absolutely. So, when could you have checked that blood sugar? You could have done the airway, ABC. You could have checked it right away, yeah, because if it was low, could you fix that? Yeah, and then would it be breathing again? Probably. Okay. So that's what we're doing. All right, how about overdose? Overdose, right, there's a lot of those. needle in his arm in the corner. We'll look at him. What do you think?
We can just go right to the dark end.
A lot of people do. You're right, because then you want to deal with them, right?
Just figure out what route you wanna go.
I know, we want to do it, but you still got to assess. You're a paramedic student, okay? I know you just want to stick with the, I used to work in Jersey City, and I had a partner that was, she was a go-go dancer, actually. And she was also a paramedic, whatever. Oh, yeah, she did. She used to strip in the crew room for money. I had no idea. She worked like suing anything.
Oh, sounds like Phil.
Yeah. Well, she used to like to get the Narcan, and she'd stick it under her tongue. She would go in the projects, she'd stick it under her tongue, and they'd wake up and they'd run off, and then she'd have to I used to, well, anyway, but you don't want to do that. Patient gone on arrival, you know. But we don't count in Jersey, they don't count drugs like you guys do here. But, so, IV, needle in the arm, it has agonal respirations, okay, and they're pale.
Let's secure that needle.
Okay,
I don't
so
want to get stuck.
sick or not sick? Sick. And you know the scene safety thing, right? I know I'm avoiding that whole time, but you guys, that should be ingrained in your BSI scene safety application and whatnot. Okay, the needle's there, you know, because if you get stuck with the needle, what do drug addicts have? Usually, they don't come out without Hep C or HIV. Most of them have Hep C or HIV because they share needles. There are needle programs. You know there are needle programs in the state where they can go to a pharmacy and get the needles if they need them, so that they don't have to share. They will give them to them. All right. So, what are you doing first? Airway. I'm looking at airway. So what are you doing with the airway? You're sitting up.
You sitting up?
Yeah, they're sitting up. Agonal, but like this.
You're
You're sitting up in the corner. You know how they do? They shoot up. They sit in the corners. They sit on beds.
Land down, open the airway.
Okay, open the airway, and then all of a sudden, his respirations are around 12.
Okay. What's the rate quality?
They're shallow. There's hardly any chest rise. What else can you use too? Pulse ox. So you want to try to bag them right? You're going to try oral airway or nasal?
Sure.
Oral's not going to work. Right. You lube the nasal enough. It's, you know, when you're done, it's a very uncomfortable feeling. Yeah.
Well, whatever.
You know, lubing something up your nose doesn't feel so good. All right, airway. So you do airway. So what are you going to do? You're going to start to ventilate them? Maybe, maybe not. If they're maintaining well. What do you mean if they're maintaining? What's going to tell you they're maintaining well? You don't have to bag them. Chest rise and pull. What else? Pulse oximetry is good. Over what percentage? Yep, absolutely. And what else can you look at? Skin color. Yeah, and temperature. I said he was pale. Most drug addicts are. Yeah. Okay, so then you got the airway done. What's the next step? You're in the A still, but there's something you do. You're up at the head anyway. What are you checking? Pupils. Pupillary response. What's the pupillary response on opiates? Pinpoint non-reactive, right? Pinpoint non-reactive. Okay, so you know you got an overdose, right? So we're doing a working diagnosis, absolutely. So I've already checked pupils because I'm up there, but normally, what stage of the assessment do pupils come into? Yeah, it's in the secondary, but we had to step it up to find out what our working diagnosis was. Pupils, pinpoint. Okay, fine, got the airway done. What do you do next? Come on, what are you doing? Breathing. So what are you going to have to do? Listen to the lung sounds. What's next? Now he's not breathing. See, yeah, this is all done pretty quickly, right? His pulse. No, he's not breathing well. Sorry. So his pulse is, let's say, 60 again. Okay. So what are you thinking you have to do, and what else do you have to do? You want Narcan, absolutely. You want to start a line, but we're missing a component here. EKG. We're going to put him on monitor. Okay, we definitely need to put him on a monitor. What if he's so hypoxic he goes into a rhythm? He could, right, before you get Narcan out? And let's think, IV drug abusers, how hard is it to start an IV on them? IVDAs, very hard to start an IV on them. Yeah, we can go nasal. We can, 1 milligram to the atomizer, right? What is that?
Doesn't work as fast.
No, it doesn't work as fast. All right, but we can also give sublingual Narcan too, which is extremely painful. You pull that piece of meat out the tongue and stick it underneath. Okay, you never seen that? There's a picture. We used to do all kinds of stuff. It's real quick. Anyway, so you're thinking IV. Monitor's on, right? IV, and how much Narcan you give? What's the protocol say? Don't give me 0.4. Yeah, give me 0.4 milligrams. What do you see most paramedics pushing?
Everything.
Two. The protocol is 0.4. You can repeat it, but it's 0.4. Okay.
Agree on their own.
All right, milligrams. All right, so give the Narcan, and you'll learn that Narcan should be given slowly. How have you seen it being given in the field?
Slam.
You're not supposed to slam it. It can cause rapid nausea, vomiting, and then it wakes your patient up too rapidly. If you go slow and just give enough to get him breathing, don't you think that's good? And have a nice quiet ride
Yeah,
to
stop
stay in the
there.
hospital? Why slam them if you could just get him breathing and get him to the hospital?
Oh, I thought you didn't give him any Narcan till you
What?
walked in the ER.
Oh, listen, you're cold-hearted.
They
Yeah.
just slam it, right?
That's like using the activated charcoal when a doctor used to order that. You do it right before you got to the ER, so they puke it in the ER. Absolutely. All right. So you just give enough Narcan, and what are you supposed to watch? You'll learn pupillary, dilation and increase in respirations. So the Narcan's given. Patients on the monitor, heart rate increases. Sats are up to 98%. He starts to breathe. What do you have to reevaluate? And airway. Where did we leave off that we have to go back? OPQRST sample. So what are you seeing here? What are you seeing? A trend, yeah. But the history is really important too. So we can't keep leaving the history out. I asked you before why someone's heart rate could be 60 when they're in distress. Where can you find out why a patient's heart rate can be 60 when they're in distress? From their medications, because medications can dictate heart rate. Absolutely, and you have to look at that. Okay, you have to look at that. Does that guy, the heroin addict, does he get a blood glucose?
Yes.
Yes.
Yeah. Yeah. I would run it. When you run it, I'd run it. Absolutely. So these are things you have to think about. So Saturday again, when you do the assessment, you have to be able to incorporate all this into your assessment. Okay? And if they ask you why, you have to be able to answer why you're doing it. Okay? Good? All right. There's not a lot to talk about. I could keep doing this, but you're going to get bored to death. Are there any questions? Or we can turn the leaf and go to something else. Questions? No? All right. What are you guys weak on patient assessment? What do you want to go through?
Somebody said chapter 10 to 12 review? I didn't.
Yeah, that'd be nice.
All right, I got some stuff.
Test review.
Want to play some Jeopardy? Want to split it up in twos?
You gotta study that too.
You got study down?
Nope.
No.
Let's just go through question 1 through 100 real quick. And,
Well, what I can do is something fun. I can split you up and we can play do teams here, ask questions. That'd be fun. All right, why don't we, let's see. We'll go, right here, okay? This side first. Who wants to start? Want to start? In pre-hospital care, I cut you in half right there. Yeah.
Don't worry, from here.
All right, what do you want me to cut? 4, 6, 7, 8, 9, and then
It's
yeah,
like
right
all
here.
in.
All them and you guys. You'll be all right. You'll be all right. In pre-hospital care, priorities of evaluation and treatment are based on what? Did you hear that?
That's not fair.
In pre-hospital care, okay, the priorities of evaluation and treatment are based on what?
Buzz. Did it.
Oh, wait. How's this supposed to work? Are you going one side and then the next?
Yeah.
Are we supposed to scream out
Do I have to
answers?
say what is?
There's a way, there's a couple ways you can do this. I can put you on the spot, I can put you as a group to answer, but I'd rather put you on the spot to answer the question right now,
Oh.
okay? And one person, if she can't get it, someone can raise their hand here and steal it, okay? I am not counting seconds, I can't keep track of that too, unless someone else wants to. I can give you like 30 seconds per question. Someone want to keep track of me?
Let's just go for if someone knows they.
Okay.
Is this chapter 13 or?
Some of this is going to be chapter 13. You want chapter 12 too? Well, it's because we're doing patient assessment. I can do chapter 12.
Yeah, but
Do some of
test is
this
on
and then we'll
Saturday
move over.
from 10 to 12. That's what's
I know.
important.
Let's do some patient assessment, then I'll go back in the last half an hour and do 10 through 12, okay, deal?
Alright. Yeah, what was that question?
The question is again, are you
Oh my
ready?
goodness.
In pre-hospital care, the priorities of evaluation and treatment are based on what? It is, but take it further. Thick or not thick? Yes, the threat of the patient, absolutely, okay? See how this works? One for them. All right, this side, you ready? Let's take you. When determining whether a patient is sick, your most effective tool is often what? When determining whether a patient is sick, your most effective tool is what?
Given it to you.
Not assessment.
The provider.
No.
Yes.
The visual.
Yes, the visual. Absolutely. Absolutely. Ah, I'm giving it to you. Look, I can play the hand game.
No,
Watch.
if you would've went like this.
Oh, like this is better?
Yeah.
Oh, it's
Yeah.
not my, all right, I'll try. All right, this side's back up. You're split, right? So you will most likely develop your field impression of a patient based on the what? I've been saying it. Field impression is based on what? I know, like 8 times during this thing.
Tram knows it.
Shrimp.
I think I know it. Cheap and plain.
And
History.
yes. Very good. Yes, yes. I'm pulling it out of you. All right. G, in the back. Asking the patient about the date, time, location, and events surrounding the current situation will enable you to do what? The what? What scale? What are you talking about? What scale of fish?
He just
Talk
named the
about.
scale after himself. The G scale.
Date, time, location, events surrounding the current situation will enable you to do what with the patient?
No, that's not, it's,
Oh, working diagnosis?
No.
Oh.
Good.
Level of
Visual.
orientation.
Yes, level of orientation.
That's your point.
Here's my point, I'm done.
AJ.
no more
Turn
time.
that light off. if you like.
Yeah, I'd like to. How do you turn it up there? Oh, yeah. Yeah, I can't see what that thing bothers me. Okay, AJ, you ready? The history of present illness is defined as the history of present illness is defined as
Symptoms leading up to the event in question.
yes, it's a chronological cap. Absolutely. Excellent. Nice. Nice.
Strong word.
Strong. That was strong.
Do it again.
You ready? The oh my God, this is so easy. The mnemonic OPQRST is a tool that does what?
Oh, brother.
A tool. Now I'm not asking you what it is. It's a tool that does what? What does it help you do? OPQRST.
Evaluate the signs and symptoms.
Determine how the incident occurred, or like the chronological order of what occurred.
Formal working diagnosis.
Yes, almost, but a little more.
Evaluate pain.
Well, what it is to rule out life-threatening or working diagnosis. Yeah, excellent. Okay, good.
What was it?
The mnemonic OPQRS is a tool that rules out conditions that are immediately life-threatening, and it can work as a working diagnosis. Okay? It makes sense, doesn't it? I think it makes sense. Okay, let's see. In the back. Fred. 7. Let's see. When assessing a patient who is under the influence of alcohol, it is most important to remember that what? When we have patients that are under the influence of alcohol. What is important to remember? What does alcohol do?
Changes their mental status a little bit.
Okay, so what are we worried about? It changes what? What can it do? What can alcohol do then? If it changes the mental status, keep moving forward. It can what?
They can mask things, signs and symptoms.
Yes, excellent. You got it. Yes, it's mass signs and
2
symptoms.
points for that.
Woo!
Well done.
Why don't you just raise your hand? It's easier. I'm on this side, in the back. The residual pressure in the circulatory system while the left ventricle is relaxing. It's not that hard. Just think about it. Just don't go easy on it, okay? Just go easy. It's not that hard, actually. Think light, okay? Relax. Yeah. Take a breath and think about it. Here we go. It's not that hard. The residual pressure in the circulatory system while the left ventricle is relaxing is called
It's Bob's question.
Bob! Oh!
Bob.
Thought I saw it. Yeah, someone told you that. Yes. Very good. I told you, take a breath when you hear it. It's not that bad. To obtain a heart rate in infants younger than 1 year of age, you should do what?
If you get this wrong, I'm gonna punch you.
Oh my God. Come on.
With my
1 year?
food.
To obtain a heart rate in infants younger than 1 year of age, you should. Jesus.
Who's it to? Oh, Grandview.
Grandview back there, Chris. Chris Lakes. To obtain a heart rate in infants younger than 1 year of age, you should. Come on. Come on. Seriously? Spit it out. Check the brachial.
Mercy.
Oh.
That's
The other's not working.
That wasn't a good enough.
You better not be. Are you a CPR instructor?
No, you are.
Oh, good. Because I was gonna take your card.
Just monitor. I'm going toward there, man.
I can read that.
Who wants one over here? Mike. A conscious patient's respiratory rate should be measured by what? Measured for how long? A conscious patient's respiratory rate should be measured how long? A conscious patient's respiratory rate. Oh. Yeah, move the other group. 30 seconds. Yes. 15 for the pulse. 15 for the pulse.
What was it?
30 seconds.
For a conscious.
Which of the following factors would not likely skew a pulse oximetry reading? Ready? Which of the following factors would likely not skew a pulse oximetry reading? Hypertension, cold temperature, carbon monoxide, sickle cell disease. Yes, hypertension.
The first smart guy in the room is a multiple choice.
That's what I'm through with that respiration.
Amanda.
Oh, you know what? They're gonna come on your side and give Ken a multiple choice.
A patient who does not respond to verbal or tactile stimuli is
The patient that does not respond
on
to,
to verbal or tactile stimulation. Sir, you okay, sir?
does not respond to it. Like, do you mean like what are they? Like are they like unconscious, unresponsive? Like,
You got it. Not responsive. Yeah.
I thought it was gonna be.
No, it's not.
Tactile or painful?
Same thing.
No, because tactile is, hey, you okay? Painful is,
That's what I'm thinking.
there's a little bit of a difference there.
Who hasn't taken one over here?
I can do it. I don't care.
And then we'll get Steve. All right. All of the following are adventitious breath sounds, except rails, bronchi, wheezes, vesicular sounds. Adventitious. Yes, vesicular sounds.
Is this like the spelling bee?
Yeah, right.
Can you use it in a sentence, please?
Yeah, what's that adventitious?
Country of origin?
Adventitious?
I think it's the last one.
Adventitious, sorry.
Somebody spell it for me?
D. Yeah.
D. Vesicular. Yes, those are normal. Adventitious is what? Admirable. Okay, who's next? Which side am I on here again? You gotta help me, I get dementia here. Wait, someone who hasn't had it, everyone here. Junior back here. I'm gonna give you one. You had one?
Oh, Kat hasn't had one.
Kat, you haven't had one?
Dude, you're welcome.
Kat, this is a tough one. When auscultating heart sounds, you should place the stethoscope where?
Which sound? What are you looking for?
Yeah, don't
On the skin.
when auscultating heart sounds, you should place your stethoscope where? On the skin. Where? When you listen, when you just listen for general heart sounds, don't get crazy. Where would you put the stethoscope?
The left of the sternum?
True, but where? Between what and what? What rib? What intercostal space?
And then second and first.
Fifth intercostal space at the apex of the heart.
You just stole that from your own team?
It's a tough one. All right. Oh, here's one. Who hasn't gone here? Stephen in the back. Abdominal guarding is most commonly encountered in patients with what?
Abdominal pain?
Yeah, abdominal guarding. Guarding is most commonly encountered in patients. Well, you would ignore this because you're cold. No, I'm only kidding.
Appendicitis.
Yeah, it actually would be. Yeah, yeah. I'll take that. Very good.
Hey,
What was the answer you were gonna give?
Peritoneal irritation.
What?
It's irritation.
What did you have?
Peritoneal irritation. I'll take appendicitis. That's good. All right, next. Oh, here, Mayor. You would most likely encounter bilateral dependent edema in a patient with. You would most likely encounter bilateral dependent edema in a patient with. Yes, CHF. Yeah. Okay, here's another tough one. I got one coming up. Who's ready over here?
Sure, I'll go.
You'll go?
Sure, why not?
Okay.
C.
In contrast to dementia, delirium is. In contrast to dementia, delirium is. There's a difference, and we see it actually in the senior citizen homes. I see my aunt.
An acute issue?
Yes, an acute mental status change. Yes, that's what delirium is. When they reach out, they believe someone's alive. That isn't alive. They start screaming, and they have it.
I get a candy for that one.
Very good. That was hard.
Cinnamons. Anybody else want one?
Do the people?
Sorry,
Who's taking it over here?
Do the people at the dollar store know you as the cinnamon guy?
Have you taken it?
Or you refer to as the guy that buys all
Are you
the.
ready? The presence of bronchi during auscultations of the lungs is most suggestive of what? The presence of bronchi.
Oh, you crazy. Yeah.
I'll give it to you. Everyone else says. The presence of bronchi during auscultation of the lungs is most suggestive of bronchi. That's okay.
Pneumonia.
COPD is wheezing. It's wheezing, but we're looking for something else with bronchi. Fever comes with it sometimes. Pneumonia. Yeah.
Do we win anything?
No.
No.
It's called paramedic. You win a paramedic certification. You win the paramedic certification. We're on this side, right? Who's taking this?
Tyler.
Oh, Colin, I missed you the whole time because you're behind your computer. All right.
notes.
typing them all up.
He's using AIM right now.
Okay.
Yeah.
10 years ago.
I'm 19.
Yeah, I don't know.
Yeah. Okay, the most reliable means of attempting to determine an unresponsive medical patient's problem is. The most reliable means of attempting to determine an unresponsive medical patient's problem is. What do you do to find out what his problem is, basically? What'd you do? An unresponsive. The most reliable means of attempting to determine an unresponsive medical patient's problem is.
You got this.
What was that?
You don't have your last name? Family members?
No. You're there, though. All right.
You know it's in-
Could be like, are you looking at like pink stimuli?
Yeah, you have to do,
Responsive.
it has to do some assessment.
CCS?
No.
Yeah, that's right.
What do you have to do on an unconscious medical patient? It's ABC. What do you have to do?
Oh, circle.
Seam size up?
A, B, C, D, E.
A head to toe physical examination. Regular, unconscious medical. Well, how else are you gonna find out what
Ask the
what else is
patient.
wrong with them?
Now.
Well, what if they are
They're there.
having
They are
shortness of
there.
breath and they fell down and struck their head? Or
The
what
families can tell you.
if they tripped over something and broke their head?
What's the family tripped over the patient?
Or the first dude.
Next.
All right, I'm getting there.
Nobody gets the point on that one.
No, you should just throw out some.
Just throw some of them out right now.
For everyone who needs.
Okay, who's up? Who's going?
I think we are.
Okay.
Yeah. Don't know.
You're up.
Anytime you encounter jugular venous distension in a patient, you should determine what? Anytime you encounter jugular venous distension in a patient, you should determine.
The level of respiratory distress.
You look like you are confused by that question.
They want to know if you see JVD, right?
Right.
What do you think it could be going on?
Respiratory distress.
looking for
down a
something
little
else.
more?
There's a problem, yes, I need a broken down one.
Left side Harper.
CHF?
It's gonna be CHF, but what's happening, but there's other things that can happen with JVD too. What's happening with the blood? That's what they wanna know. What is it?
Why is the blood backing up?
You wanna know why the blood, so why is there a venous obstruction that's impeding blood to the heart? You need to know why. So when you look at JVD, you should be thinking that way. Yes, we know CHF too, but what else could you have JVD with? Tension pneumothorax. Right, but, okay, so you just see, or what else could you have it with? Yeah, see? So you have it's an obstructive type thing. So you have to look at that when you look at JVD. See, so this is good.
So the answer is
The answer is where the venous obstruction is that is impeding blood return to the heart. Okay? All right, we're on this side. It doesn't read well? Yeah, it does. At least, but when you look at the answers, it reads better.
see, we don't have the answer, so we're guessing. We're shooting in the dark.
That's good, that's good.
Right.
Ready? Caring for an unresponsive trauma patient, a complete secondary assessment will do what? When caring for an unresponsive trauma patient, they're asking, do you do a complete secondary assessment? Caring for an unresponsive trauma patient. I have to give you a break in 2 minutes.
When character responsive patients, do you do any secondary stuff? Is that a yes or no question?
It depends.
If there's time.
I know,
Right,
right?
it depends on if you stabilize their life.
Absolutely, it depends if you complete it, if you have time, because you have to stabilize that airway and any bleeding or any problem with the chest. Yeah, absolutely, good. Okay, all right, we gotta go to break, because it's 8:30, so what we'll do is give you 10 minutes, I'll come back and I'll do some review, but shh. All right? Are you enjoying this? Was this good? Did you like it or not?
The questions without the multiple choice are a little difficult to pick up, but
They are. All right, so I'm gonna go get some stuff.
I think talking through it is making me a little easier.
You got coffee. There's so much I can do for this today. I'll be back. Hanging in there?
Fine.
Yeah, tired?
No, it is test at the end of the day. That's, yeah, it's a test.
That's at the end of the day, yeah, because the stuff that's included in the pills are people hard to have. Because I want to give you the quiz that has those drugs on it for chapter 12, so that you can take it immediately.
You got one?
And there'll be other. So every station you go to, there'll be a you have to complete all the tasks.
With- So those were all like chapter 13.
All the drugs,
patient
farm.
assessment.
That's like what's holding me back. I'm hoping it'll get better
There's
though,
so
like
many
once
tests
we
that
like
start
start
you,
with those
I
visual
appreciate it.
systems,
stuff like that.
like respiratory,
How much more do you want
then
to
I can
do?
actually place the respiratory drugs with what we're learning about the respiratory
You
problem.
can.
Okay, so
I
this
think it's
could be
important
on
skill
me.
group, I think with a skill group, when you're actually doing it, you're thinking and you're moving, and you gotta practice
It
at
took
home.
somebody to be on that day and tell me
In
that.
your head. And we're not gonna always go back.
You
So if
programming
you
on
see
computer,
something, you gotta go back where you left off, that's really important for you to pass national registry.
They didn't even tell me that. I think it's my fault. I think the operator error there. I probably didn't listen.
You didn't grab in your brachial, you thought I just wanted to hold you? Is that
I was
know
like-
what's happening? Thought I just
Somebody said monitor. I'm like, I don't think that's right either, but
I don't know how appropriate it is for.
Yeah, I don't know.
us to having 90 minutes though, but I was thinking,
everybody else again, like,
some of the times that we do assessments and stuff, if we could, because we're always doing adults and stuff. if we could bring my
Yeah, we can eventually, I think that's great, I do it over there, the other place.
My son has a lot of cardiac stuff, so when we do like monitors and stuff, you can see the difference. I think the difference.
Yeah, I don't find a problem with that, we do pediatrics, it'd be nice to have
Is this cheese?
Sometimes the wife
Yeah,
sets down over mine.
I would want, I'd love to see, I know you're,
I think I'm
you're
guessing
holding the baby, no one's gonna assess that baby.
No.
Once, the other day, I almost got stuck.
They must
She wasn't home yet. I was like,
Yeah.
I got it.
You may have to sometime, and switch them off,
Is it
you know, or we'll take
You
it.
said
Yeah.
the assessments on them and
I love these packets, man.
really liked it.
You got used to
They're
it.
not all
grades?
like.
Do you know, some of my kids are
No,
growing up,
G
they always came to class with me too.
Some
and
grades?
I know everything, yeah. It's funny, they get real comfortable with it too. Yes.
Grapes. Now we're just gonna bottle one.
Well, the test grade, yeah, let's go and get it, we have it in end grade. So, look, we get it. I can see it back. Pull it up.
Not very
Why did I feel like we didn't have a test today,
Damn.
on Saturday?
What?
Why did I feel like we we did not have a test on Saturday.
I don't know, I've been talking about it all week.
You have?
Have you?
I like really.
Pharmacology
forget
is
that we
just-
didn't have one.
Did you study any of the medications?
Some, yeah, I've tried, but it's like nothing's sticking.
Oh, because it wasn't there. It was on the other side. Check that out.
I'll meet up tomorrow night. Anyone wants to meet up? No.
You live far, right?
I live up. I'll travel. Don't mind.
Blue Bear's not far from me. I might do that. I was
Okay. I might meet up with Amanda and Fred.
They live far.
Okay,
I live in Norristown. It's like 10 minutes from
we
the.
live in down in Tyndale.
Oh, lower box.
It's like 2 minutes from here. That's what you could say.
I'll do a phone thing with them though. Speakerphone.
Skype. That's what he did.
Yeah, how well did that work out?
It worked pretty well, man. It was like you were right there.
So, I'm like, I don't know.
Usually stay up all night.
What drugs should we focus on then in 12?
Ask
Like all of them.
So, we
And all
won't,
the details.
we won't really know until we do the station on Saturday.
Then how the fuck can I study them?
Right.
You can't.
That's what.
Yeah.
I'd rather
That's
know
tough.
them now, that way I can prepare for when I'm using them in the clinical, like in the lab.
Just they ask
That
you
way I
questions.
don't have to learn that in the lab.
They ask you questions assuming that you already know stuff about them.
Because I'm gonna study all the other stuff, and then they're gonna throw that at me, and my brain's gonna be like, fuck that other stuff, I need to memorize this. I'm gonna go talk to her. Yes. I need to fucking know. At least 3/4 of them. I don't care if I don't know all of them.
Meet up tomorrow night.
I've been working for 2 weeks on just drug, generic trade name, and general classification. I still don't have it.
I started looking each drug for like a day or two, and I'm like really big on visual and seeing people and remembering that kind of stuff. So I've been looking up drugs on YouTube and watching people give them. Like they have ones where they're like, the other day we were doing the partisan, and they'd be talking to people or whatever. Yeah, like clips.
Class 4 antidepressant. Class 4 antidepressant.
That stuff I can memorize for a really short period of time. Really, really short. And then it's gone.
I'll put my work.
Once I understand it.
I have market at work.
Oh my god, I didn't notice that. That's gonna bug me now too. Thanks.
I've
Appreciate it.
I've noticed that ever since, man. I was like, God, that's so annoying.
Larissa, am I showing YouTube my crotch right now?
Listen, someone's got to take this away from me because I've been hitting this pretty hard for
See
like
it?
the
I
last
can
4
picture
minutes.
it. I picture the lady.
No, I guess.
Yeah, no.
What?
Or,
Talking about activated charcoal. Not talking about the game. We're talking about activated charcoal.
Narrow complex.
Gator, what's this activated charcoal?
What in the F are you doing?
your mom.
Gator wants his money.
Yeah, so it's SDT.
Or your dad.
SDT.
Yeah.
Is it?
But so it's
And then that
your,
pushes
it's
it
your
back.
narrow complex tachycardias. Or sorry, tachy.
What is that guy saying?
Aspirin.
Acetylsalicylic acid.
Joke to see if she was going to give an answer.
What? That worked on me. Plus my other half is that.
Where did the asterisks form?
He asked us to put some of the questions that I put on the test, but you're gonna see some of this stuff during the skill stations. Some of the drugs I used.
What the hell was that?
What? What's what?
Oh my god. Do you know what Kayla said to me? Do you know what Kayla
What
said
was
to
our
me?
password for the?
She's like, so she took some pre-workout.
It should be the same as your
Which is-
FC log.
My pre-workout, which is really, it's a stimulant. And if you don't start working out and really hitting the weights hard, like your face tingles, your ears tingle, your hands, I mean, everything just tingles, and it's like, it's just like the whole body just starts like tingling and, weird.
I told her,
I told her not to take it. I told her not to take it, but she takes it. And she said, so she took Benadryl. And I'm like, what'd you say?
Are these things that stick you together or
I'm taking Benadryl. You don't need it. It does that. It's not an allergic reaction. That's an effect of what happens when you take this shit. And she's like, yeah, but this it's the allergy kind. It's the allergy kind of Benadryl. And I was like, wait, excuse me? And she said, I'm like, is there a different kind? And she's like, yeah, there's a non-allergy, and there's the allergy kind. I'm like, I think you should look at the back of that package because it's going to tell you that there's 25 milligrams of diphenhydramine in there, and that is for allergies. And she's like, no, it's not. And I was like, all right, well, you have a good day.
Benadryl? I'm allergic to Benadryl.
So you get a lot of racemic epic.
Yeah, actually, never there's a test, they get it on board. Yeah, I have this on my reflexes.
Phone test.
Give it.
It's kind of weird.
Would be in contraindications.
No, you're giving
And adverse effects. I drink a glass of alcohol, I get them, so, yeah.
I thought you were being serious. I was like,
That's why you work
Two
the gloves.
them in the bag, 3 I'm really for. Yeah, I'm a very cheap date.
Do you like beer? Because I have some high touch beer at home.
Do you? I like to try some
Can you
beer.
bring
I've
some
never been a
sack?
beer drinker, except when I was in college. I drank a lot of beer.
Green cakes.
I had a whole growler last night.
Yeah.
Just hit it hard.
Me, you want me?
No, I should move over.
You ready? Oh, you want me to move?
Yeah, I'm too lazy to write them down.
Oh. Did you get it? We're good. Okay, so, I told you the drugs. Now, there's only one or two, you should know these two, right? These are two snapshots you take.
Don't forget Narcan's gonna be on there too.
Oh, yeah. Yeah, I did put mine. Thank you.
0.42 milligrams.
Actually, do it back.
But very basic questions, and like I said, you'll see them during your skills group, so don't get too nervous about them, all right? I have them here, I'm not gonna go over them because you're gonna get them in skills.
People are lazy.
It's like you are so lazy.
How many are done, snapshotting? Good?
I wrote them down.
We should probably Snapchat that.
Yeah, it's good.
That's what
good
then it'll
tweet.
disappear.
I don't have Snapchat.
You got a screenshot of it.
You know,
Speaking of Snapchat, tag.
The phone app on my phone doesn't work quite right, so
your phone's not working right?
it's not the phone app. It's a bad joke.
All right, let's look at some stuff. Let's see what I got.
Is that the time?
What else do I have in here? The question is 100 questions.
Like, clear yourself out.
Yes, all tests.
She works.
Huh?
Questions, 100 tests.
Now, is that what I said? I'm like screwing it up left and right. The question's 100 tests, so
Yeah.
I'm telling you, I'm tired. I'm actually very tired. I didn't get much sleep last night. All right, let's do this real quick. Let's look at some stuff.
Let's do a lot.
Let's do a
Just
lot.
like Nike.
We'll do it. Just do it.
Okay, I'm just gonna ask questions, all right?
See.
Actually, yeah, very good. Okay, what's the recommended temperature to store medications? And I don't see that happening here in Pennsylvania a lot. What's degrees? What's the recommended temperature? How much? What is it?
22 to 25 Celsius.
Give me Fahrenheit. I'm not good with Celsius. I know what my Fahrenheit is.
Probably
55 to 86.
55 to 86 degrees. Do you see that happening? 55 to 86, yeah, most meds. You know what I see? I don't see my meds being refrigerated here. Anybody have refrigerated meds in their trucks? Are your trucks? in
Right now,
refrigeration?
yes.
We did until our truck caught fire.
Do we need to know it both ways or just in Fahrenheit?
You need to know 55 to 86, just a Fahrenheit. We're just doing a Fahrenheit, okay? Yes, because I know where I work, in the summertime, the garages are hot, right? They're getting to 100 degrees. So what happens to your medications when they go over 86 degrees or below 55? I would say they become impotent. Yeah, they don't work right. Absolutely, absolutely. So you gotta watch your temperatures, and I don't see a lot of temperature regulation out here. Okay, newer medications, okay? Newer medications, let's talk about those. They're designed to target only specific receptor sites on certain cells and attempt to do what? Why are you?
Reduce side effects.
Yes, minimize side effects. Yep, absolutely. Good.
Go girl.
All right, good. We'll look at some of this stuff. I'm gonna deny it. We're gonna go into a lecture. Okay. Antagonist. If you call a medication, if a medication is called an antagonist, what is it? Why is a medication called an antagonist?
Stopping something.
It blocks a receptor site.
Okay, yes, it blocks, yes. So it has what? They talk more terminology. It has a higher what?
Higher affinity for the receptor sites.
Than the chemical one. Yeah, absolutely.
Thanks, brain.
So
What'd you say? What?
what was the answer?
Thanks, brain.
It has a higher affinity for the receptor site than the chemical mediator.
So CO is a good example compared to oxygen. Higher affinity for the hemoglobin. So therefore prevents bonding.
Okay, beta-2 receptors. Let's talk about beta-2 receptors. What do they cause? Beta-2 receptors. They do. You know, you guys are gonna laugh. I shouldn't even tell you this stuff. When I was on Plenty of Fish meeting the guy I'm with, my name was Beta-2. All right, let's keep going. You'll remember that
So
one.
you were
now.
trying to relax? Is that?
Wait, you use Plenty of Fish for a long-term relationship?
Yeah, that's how I found them. Plenty of Fish. Well, you know, I'm older. I don't go to bars like you guys. You don't hang out.
I remember my wife threw some of those.
Hey,
days,
Mr. Mingle?
See? His name was Prime Beef. Prime Beef meant Beta-2.
Hey Jay, you're on JD.
Surf and turf.
That'd be funny. Okay, I can't give you everything, so that's why I'm looking through to see which ones I can look at. Okay, give me the answers too.
Yeah.
Okay, when you stimulate beta-1 adrenergic, when you stimulation of beta-1 adrenergic, someone get it out for me?
Adrenergic.
Thank you, receptors, what do you produce? What type of effects?
The beta-2.
Increased heart rate.
Beta-1.
Increased heart rate, increased contractility, increased
Conductivity.
Right,
conductivity.
absolutely, yep, all of those. Got them? Did you
Is
get
it
them?
also renin secretion?
What was that?
Renin secretion to.
Renin secretion to up the rate. So what are the three again, so everybody knows? Come on, please. Increased heart rate was one. Increased renin secretion. What was another one? Increased cardiac, you said?
Induction,
Right, electrical induction.
contractility.
That's it. Okay.
Can we talk for a minute about digitalis toxicity?
Yes, let's finish this and we'll go into dig. Okay. A medication that possesses a negative chronotropic effect does what?
What was this?
A medication that,
Decreases heart rate.
that's all right, you got it.
Can you say it again?
Sure. A medication that possesses a negative chronotropic effect will
Decrease heart rate.
decrease heart rate. Okay? Let's see.
Real quick, so if it had a positive counter effect, would it increase?
Yep.
Yeah,
So
so-
like atropine.
Right.
Positive control.
Beta-2.
So you have your ino, which is your strength of contraction, and your chrono, which is your rate.
Rate of contraction, right. You have to know those two words. Okay, let's look at this. Patients that have pulmonary hypertension may experience acute decompensation if they are given what?
Say it again.
Patients with primary pulmonary hypertension may experience acute decompensation if they are given a what? That'd be choice. Well, it's not a bronchodilator. It's not, would you say, nitrate?
It's not a vasodilator.
Wait, what are they experiencing?
It is a vasopressor. Vasopressor,
Well,
And they're beta
That'll
blocker.
be flash, right?
Beta blocker.
yes.
Can you read the question?
So,
Patients with primary pulmonary hypertension may experience acute decompensation if they are given a vasopressor to open it up. Okay. Ooh.
I thought a pressor always contracted. Vasopressors.
yeah, but they already have hypertension, right? So we're
You
gonna-
already have hypertension, so the vasopressor
Result.
we make it more.
would be the opposite, so it contracts you, right? It doesn't dilate, right? So that's why we kill them. So it's true.
Okay.
Yes. The vasopressor presses down. Yes.
So it drives the pressure.
Drives the pressure up. Right. So they will decompensate if they're given the vasopressor.
Will that induce a flash pulmonary
It
edema?
will induce flash pulmonary edema. Yes. Oh, God. What are you gonna do? What?
What's
I can only give you a couple more here.
Like 85 more?
A paramedic. I can't believe I'm doing this. A paramedic gives a woman with chronic pain an injection of sterile saline and tells her that it's a narcotic. I can't talk about it. Help me.
That is
Thank you.
unethical.
I know. What's paramedic's action? It is unethical. Well, what can happen?
There's negligence involved.
And it can result in criminal, what? Prostitution. Prosecution. I can't talk today.
Prostitution is also criminal.
You losing your what? Certification. Okay, it will lead to you losing your certification. Okay. Let's see. I'm trying to look at some more of these that you, okay. What conditions would make a patient most susceptible to an adverse effect from a medication? Hypertension, renal failure, minor trauma, or chronic pain?
Renal
failure.
Third man.
So there are some hard ones and there are some easy ones.
Let's go with the
Should we just take the test now?
No.
With the group test?
What about teamwork? On the
Yeah,
board.
can we take the
Join
test on
team.
Teams?
Oh, I didn't actually do it.
Yeah, right.
Sorry.
Oh, I have to.
Oh, yeah.
I'm looking, I'm going through, okay, I'm going through. What's potassium do, by the way? Yeah,
Muscle contractions.
yeah, it does, it plays what, a part in what, neuromuscular function. Potassium. Okay, look at another one here, let's see. Pumping sodium out, I think, didn't Ben talk about this one? Pumping sodium out of the cell and potassium into the cell has the added benefit of what? What happens when that happens? What moves in? Water. And? What else? Glucose. You want to hear that one again?
Yep.
Pumping sodium out of the cell and potassium into the cell has an added benefit of moving what in? Glucose. All right. We talked about overhydration, right? We talked about it a couple times. So what's happening with overhydration? What's happening with overhydration?
Can make a cell burst.
I don't know if you
Yeah.
understand what I'm reading.
Overhydration, cell burst, what happens?
Dilute what's in the blood.
Fluid is forced into the interstitial space, right? Makes the cells burst, right? And then it goes into what, the intercellular compartment. Lactated ringers, you remember that one?
Don't give it
Don't give it to who?
alcohol.
Okay, and why? What kind of problems do they have?
Liver.
Liver. And what is it good to give it to? What types of patients?
Trauma.
Trauma. Why? I don't have the question, my notes in here. Why?
Because it's metabolized and then it's like,
And it stays longer, right? It creates a space, fine. Okay. Oh. The veins again. When selecting a vein for cannulation, you should avoid areas of the vein that are what? Everyone got this. Passes over what?
Joints.
What's the chances of looking at our other tests? That's a study guide.
Can't give it to you. Vasovagal reaction is a result of what?
What was it?
A vasovagal reaction. What's a vasovagal reaction?
Drop in the heart rate.
It is. How does it happen?
Increase,
Shock.
your vagus
We see them all the time.
shock, suppressing your vagus nerve.
It is. And how do we see our patients? Where do we see our patients with this? They're on the
Taking a
share.
poop,
You're talking about bearing down.
when they're 90 and taking a poop and then die.
Question?
or your Elvis,
Absolutely, because what's happening?
bearing down.
Oh, yeah.
That would have been hilarious. She passed out.
Yeah, yeah, especially my age. Nobody do anything. Just whistle on makeup.
Can you read that question again?
It says, the vasovagal reaction is a result of what?
Come on in.
What's the, what?
Can we get that last test back?
Bearing down.
Well, what is it?
Fracture circulation.
Say what it is?
Fracture circulation in the vagus nerve.
It is, overstimulation of the vagus nerve. Let me see.
Okay.